All right, so this is the second part of our neurologic issues, part 2, unit 7. We're going to start with Guillain-Barré syndrome. Easy way to remember this or differentiate it from myasthenia gravis is Guillain starts with G, so the patient starts to have paralysis from the ground up, from the feet up. G for Guillain, ground, G, ground up. Ultimately, this is an autoimmune disorder with an acute attack of peripheral nerves, spinal nerve roots, and cranial nerves. So your body starts attacking itself on the nerves. And it's going to be your extremities and eventually up to your spine and into your brain. But always remember, it's going to start at the ground up. So starting at the legs and moving upward. The immune system starts to destroy the myelin sheath that surrounds those axons, those neurons. It's characterized by varying degrees of motor weakness and pathology. So what are our risk factors? Exact cause is not known, but it is the result of an immune-mediated pathology. So some people may experience this after a severe illness, or maybe they get a live vaccine, anything that's going to affect that immune system. It has also been associated with a bacterial infection. I will die on this hill. Epstein-Barr is what causes a lot of problems, especially later in life. It can cause lymphoma. It can cause all kinds of cancer. It can get reactivated. It is the bane of everybody's existence, and it can lead to autoimmune issues. Some other things would be like the flu, Zika virus, some vaccines, cytomegalovirus, which is a virus that you see a lot more in your immunocompromised patients. Some people can heal from it and some people can't. And all of these have been associated with your GBS or Guillain-Barré syndrome. So this is just an example of what happened. This is a healthy nerve. If we get Guillain-Barré, that autoimmune disease, our body starts attacking this outer layer and it leaves the nerve root open. We never want that to happen. Our nerves should be protected with this myelin sheath. So recognizing our symptoms. Of course, there's going to be motor symptoms, there's going to be sensory symptoms, and autonomic manifestations. So your motor, sudden onset of ascending bilateral symmetrical muscle weakness. So it is going upward from the feet up. It is on both legs and it's symmetrical, so it's going to start at the toes and move all the way up to the ankles and so on. Keeps going up. You could see the muscles being flaccid, maybe even completely paralyzed. Decreased deep tendon reflexes. Eventually, if it gets up into the truncal area, you will see respiratory compromise, loss of bowel and bladder control, and ataxia. So you take that myelin sheath off of the neuron. Of course, the neuron is not going to be synapsing the way that it should. It is also going to have sensory perception issues like paresthesia and cramping. By the time it hits the head, you're going to have facial weakness, unable to swallow, maybe double vision, diplopia, and difficulty speaking. Now, your autonomic manifestations, autonomic means like your vital signs. So your blood pressure is going to be unstable. Cardiac dysrhythmias and tachycardia. Think about your neurons. They run the show on every part of your body. So if they are not synapsing, your muscles aren't going to be working. You're not going to be able to have sensory or feeling. Your heart, it beats because of neurons telling it to beat. So your phases of GBS, acute or initial period, that can last 1 to 4 weeks from onset of symptoms and ends when there's no further deterioration. Now phase 2 is the plateau period. So this could be no further deterioration has occurred, and this could last up to 2 weeks where you're just sitting in limbo. Phase 3 is the recovery phase, and this sometimes can take years to get back to normal. Well, not even normal, somewhat normal. There could be permanent damage. So if permanent neurologic deficits remain, their condition is referred to chronic Guillain-Barré syndrome. So your diagnostic test, we can do an LP, lumbar puncture, and that's going to show us elevated white blood cells. Remember, it is an autoimmune issue. Your body is attacking itself, thinking that there's a foreign body in our system. So it's going to activate our immune system to say, hey, come here, come help me clean this all up and get the invasion out of our body. So elevated white blood cells. You're going to see nerve conduction issues. You're going to be looking at those tendon reflexes. They're probably not going to have reflexes. You are going to see them, or you ask them to wiggle their toes. They're not going to be able to wiggle their toes. We can do an MRI, ultrasound of those peripheral nerves. Of course, we are going to look at those autoantibodies. So we're looking at biomarkers because that is what's happening in the autoimmune disease. And then this patient should probably be seen by a doctor, and if not, the hospital, because once it starts going up to the trunk, they can stop breathing. So your medical management. We worry about paralysis, not being able to move, and then eventually heart is not functioning the way that it should. Your vessels are not functioning the way they should, so lack of blood flow, and then your respiratory system not working. And then they run the risk of aspiration, all the big complications. So eye movement, speaking, chewing, swallowing, those are all going to be problematic. So we have to make sure that we're taking care of the eyes. They're no longer able to blink, so we're putting eye drops in. Speaking is going to be an issue, and of course, if they're not speaking, they're probably not moving their hands. Chewing and swallowing, that's just a no-no. At that point, we are not giving them anything by mouth. They could have total paralysis. It is potentially dangerous due to once it reaches the truncal area because of our heart and our blood pressure. So dysrhythmias can be very problematic. 25% are unable to breathe without respiratory assistance. This is why it is so important for that patient to go get checked out by their doctor and get started on the regimen early, because as it progresses, it can go up into the chest area and cause lots of havoc on your big organs that keep you alive. Often, these patients are going to need long-term rehab to regain normal independence. As many as 15% experience lasting physical impairment, and 3 to 8% can be fatal due to those complications. So emergency nursing management of Guillain-Barré. Airway, breathing, circulation. So maintain that patent airway. Elevate the head of the bed. Get your chest physiotherapy, your spirometry done. Monitor your neuro status, respiratory status, and cardiac status frequently. They will likely, if it's already ascended up to the truncal area, they likely need to be intubated. Pain management, monitoring sensory, further damage, promote communication. Of course, you're going to help with the support, get social work involved. Long-term care, make sure that you're talking to them about long-term rehab or even a ventilator that may be needed. But airway is the most important. So our treatment, it's an autoimmune disorder, so they need to be aware of exacerbations of autoimmune diseases. Remember that autoimmune disorders usually occur due to too many killer T cells or too few suppressor T cells. And what causes the killer T cells to be really activated is an attack on your immune system. We can treat it with plasmapheresis. That's going to decrease circulating antibodies, IVIG to help the immune system out, which we're giving that patient immunoglobulins to help fight off those antibodies. They may need some treatment for their blood pressure, frequent respiratory cardiac monitoring, and then your PTOT, ST therapies, maybe even a dietitian. So our question, the nurse anticipates what diagnostic test to confirm Guillain-Barré syndrome? The answer is B, lumbar puncture. That is going to be the best indicator. We are going to be looking for elevated proteins and normal white, or it's going to show elevated proteins with normal white blood cells. A patient admitted with Guillain-Barré syndrome requires which priority monitoring? It is going to be B, respiratory function. The priority is your airway and your respiratory status due to the risk of respiratory failure. Which clinical manifestation is expected in Guillain-Barré syndrome? Select all that apply. Ascending paralysis, so A. B, symmetrical weakness. And D, slow progression starting in the feet. So GBS is ascending, ground up, it is symmetrical, and it starts in the feet. They are going to have hypoactive reflexes, so not hypo. And sensory loss, they will have some sensation in some areas. It's not a complete loss. Which treatment should the nurse anticipate for Guillain-Barré? Select all that apply. So that's going to be your IVIG, giving them immunoglobulins, your plasmapheresis, and then your mechanical ventilation. We are not going to be treating them with antibiotics because they do not have, unless they have a bacterial infection that has triggered that Guillain-Barré. Otherwise, antibiotics are not directly linked to Guillain-Barré. And your steroids are not going to help. Now, the other neurologic issue that we're going to touch base on with this is myasthenia gravis. So this is another autoimmune disorder that attacks acetylcholine receptors at the postsynaptic muscle membrane. This one starts at the head and then descends down. So Guillain-Barré ground up, myasthenia gravis starts at my head down. It's going to be more men, seen with more men, usually elderly men, 16-80. It can happen in women. Typically, it'll be younger, 20 to 40. And our pathway behind that is normal impulses travel along the nerve to the ending and then release the neurotransmitter acetylcholine. We need acetylcholine in our daily life so that we can regulate memory function, movement, muscle contraction. It does a lot. However, if your patient has an autoimmune disease, myasthenia gravis, they are making these autoantibodies that are attacking the receptors on acetylcholine, so acetylcholine cannot get into the next neuron. So it's going to prevent muscle contraction, ultimately leading to paralysis. So starts at the head. So we are probably going to be really concerned about this one over Guillain-Barré. Yeah, they're both very concerning, but the head is much closer to all those organs that keep you alive. And especially in the back of the head, think about your medulla. That's our breathing center. So things that you will see. Ptosis, so eyes that are weak and maybe just like lacking, they're halfway closed, or drooping, that's the word I'm looking for. Diplopia, so double vision. Problems with chewing or swallowing, dysphagia. Decreased senses such as smell and taste. Limited facial expressions. Remember, this is attacking that acetylcholine receptor, and we cannot have any muscle movement. Slurred speech. Eventually, you're going to start seeing a descent from the head down into the truncal area and into the limbs. So, weakness of arms, you're going to start to see hypertension, tachycardia, tachypnea, respiratory paralysis, and then respiratory failure. This one is, they're going to see more progression quicker with the respiratory issues. So it can lose muscle strength for breathing, and this patient will likely need a ventilator. So, how do we diagnose it? We are going to do an EMG test of the muscle fibers, ice packs on the eyes to resolve the drooping eyes, CT MRI of the thymus gland. So the gland's going to be enlarged. This is where those T cells are made. I would like to get into the nitty gritty of that, but I know we don't have time. So yes, most of our immune system cells are made in our bone marrow. However, when we're talking about the lymphoid stem cell, it branches off into your B cell and your T cell. Your T cell goes to your thymus, that starts with a T, and that's where it kind of hangs out until it's needed. So if we have an overabundance of T cells being activated because we have an autoimmune disease, of course that thymus area that's in your chest is going to get enlarged. It is an autoimmune disease, so we are going to test for ANA, anti-nucleic acid, looking for those autoantibodies. And then this affects your acetylcholine. So we're going to be looking at anti-cholinesterase, the enzyme that breaks down your acetylcholine so that it can be reabsorbed. A positive result is an increase in muscle strength if we give cholinesterase inhibitor or your tensilon. A positive result means that they're going to have muscle strength within 30 to 60 seconds after the medication. That's going to last for about 5 minutes. However, it's going to go back away because that receptor is broken. So our treatment, cholinesterase inhibitor drugs, so anti-cholinesterase drugs. This is your first line management. Remember, it's acetylcholine, the receptor that's being attacked. So if we stop the enzymes from breaking down acetylcholine, like your anti-cholinesterase or your cholinesterase drugs, that's your enzyme. So if we stop that enzyme from further breaking down acetylcholine, then we can have some muscle movement. So those drugs are neostigmine and pyridostigmine. That's going to increase that muscle strength, enhances neuromuscular impulse and transmission. Therefore, it's going to increase the response of the muscles to the nerve and then to the muscle. We're going to give them corticosteroids, high doses of IVIG, and then plasmapheresis. So nursing management, the priority for nursing management of the client is respiratory function, promoting gas exchange, making sure that they're still breathing. This will likely be a result of them being intubated. Getting them having suction at bedside in emergency intubation, suction kits, all of that at bedside. Assessing for the gag reflex. If there is no more gag reflex and we know that they are positive for myasthenia gravis, we need to make sure that we have intubation stuff ready. Provide oral hygiene, collaborate with a dietitian. We are not going to give them food unless they have a gag reflex. So your book says cut food into small bites or soft diet, but we're definitely going to be consulting the dietitian before that. Observe for choking and aspiration. Keep the head of the bed elevated for at least 30 to 60 minutes after eating. Consider thickened liquids, daily weights, and then we need to give them that first line treatment, the anti-cholinesterase drugs. And we give that 45 to 60 minutes before meals. So myasthenia crisis. This is an exacerbation of that autoimmune disease. So a flare-up or worsening of the initial exacerbation. There is not enough anticholinesterase drugs given to that patient. So remember, they don't have acetylcholine because they can't get onto the receptor, and now we have all these enzymes breaking down the acetylcholine. Well, we have to give them an anticholinesterase drug, and maybe they don't have enough of that drug in their system yet. That can send them into a crisis. What does the crisis look like? It is increased heart rate, increase in vital signs. So heart rate, respirations, blood pressure. And then all of a sudden it is going to drop. So respiratory failure, you're going to see an absence of cough and swallow reflex, bowel and bladder incontinence, severe generalized muscle weakness, immediate respiratory emergency. So always remember your airways priority. You're going to have the intubation stuff ready. Keep your bag, valve, mask set up at bedside. And then we're going to give them the tensilon test to, if we give them the anticholinesterase drug and they improve within that 5 minutes, then we know that we need to keep giving them the drug. So causes usually immediately after a respiratory infection, what causes the crisis. Remember, anytime you have an autoimmune disease, it does not go away. So it could be an exacerbation due to another infection. Or it could be that we don't have them on enough drugs, or it could be a result of severe stress. Now, cholinergic crisis. So kind of the opposite. Maybe we gave them too much anticholinesterase drug. This is an acute exacerbation of muscle weakness caused by too many anticholinesterase drugs. So we're going to stop the drugs. Your patient with myasthenia gravis is getting that anticholinesterase drug. Now we've given them too much and we need to stop. Things that you will see: bradycardia, bronchospasm, flaccid paralysis. Patient may need to be intubated and suctioned. They are going to have hypersecretion. So we need to give them atropine to dry them up. Nausea, vomiting, abdominal cramps, worsening symptoms when we give them the tensilon test. When we give them the anticholinesterase, the whole problem is the cholinergic response. We don't have enough of it anymore, so no choline left. And if we don't have choline, we are kind of wet. Everything is slow and wet. So those bronchospasms, we need to dry them out a little bit. So what statement best describes myasthenia gravis? It is an autoimmune attack of acetylcholine receptors at the neuromuscular junction. Which clinical finding is most consistent with myasthenia gravis? Answer is ptosis and dysphagia. That is the drooping eyes and the inability to swallow appropriately. Remember, myasthenia gravis starts at the head and the face, and then it descends down. Which equipment should be kept at the bedside for a patient with myasthenia gravis? And that's going to be your suction and emergency airway equipment. A patient receiving pyridostigmine develops hypotension and increased secretions. Which is the priority intervention? That's going to be stop the medication and give atropine. We're giving them too much of the anticholinesterase drug, so now they're in cholinergic crisis. They're too wet, so we need to give them atropine. Which finding suggests myasthenia crisis? Select all that apply. So myasthenia crisis is hypertension, tachycardia, tachypnea, and then respiratory failure. Everything is sped up and then they conk out on you. So everything's rapid and then it starts to fail. Now your ALS, or amyotrophic lateral sclerosis, an overview of it. I'm sure you guys, I hope you guys remember the Ice Bucket Challenge, where people were donating money while they dumped ice over their head for ALS. This is a terrible disease. Lou Gehrig's disease is what it's called. It is awful, awful. The body stops working all except for the brain, really. So the patient can hear, they can see, they understand what's happening, but they are not able to move or speak or eat or breathe on their own. So it is progressive neurodegeneration of motor neurons in the brain stem and spinal cord, leading to asymmetrical muscle weakness and wasting, paralysis of voluntary muscles, especially those affecting the respiratory system. ALS is asymmetrical. Sensory pathways are intact. So they can hear, they can see, they can understand, they can smell. They just can't move. So no established treatment or cure for the patient. It is 100% fatal. Patient will typically die within 3 years of diagnosis due to pneumonia. Commonly seen in ages 40 to 70, affects more men than women. We don't know why it happens, so cause is unknown. And the other name that we can hear it called is Lou Gehrig's disease. So how do we diagnose this? This is also very difficult. So it's diagnosed through ruling out other causes. We're going to do a muscle biopsy, an electromyography. So looking at the electrical impulses sent to the muscle. Clinical manifestations, you're going to see fatigue, muscle atrophy, including the tongue, muscle weakness, twitching of the face and tongue, dysarthria, so the joints no longer viable, dysphagia. So stiff and clumsy gait. I don't think I said dysarthria is the speech impairment. Abnormal reflexes. Usually the first muscles affected are those in the arms and the legs. It is ALS asymmetrical. ALS asymmetrical. Management of ALS. So they are going to decline, and there's nothing that we can do for them, unfortunately. But yeah, we can prolong their life with ventilators, G tubes, all the stuff that can keep a patient alive. And then some patients get their will and testament done before they progress into that. And they make their own decisions. I don't want a feeding tube. I don't want to be on a ventilator, all that stuff. So we're going to focus on the quality of life for that patient and what they want out of their life. Treat the symptoms in rehab. Start early. We are going to get them into rehabilitation system to prevent immobility complications. Start them on medications. Riluzole is extends the survival time of that patient, but it is toxic to the liver. We can start them on adaravone as an IV infusion, antispasmodics, your inducers of your diazepine. Dantrolene is also a muscle relaxer. Pain control NSAIDs or tramadol, and then your antidepressants. Remember, sensory pathways are intact. They can hear, smell, taste, understand what was happening to them. They just can't do anything about it. Nutrition, trouble with eating and drinking over time, and they will get a G-tube placement if that's what they want. Psychosocial support, especially for the families and the children that are involved. Palliative care and hospice. Being a hospice nurse, we did see this quite a bit, and it's heartbreaking. Hospice is there to help manage the family and help with the whole following through on what the patient wants out of their life. So symptom management, end-of-life care, helping them get affairs in order, and just being supportive. We are going to monitor the respiratory status and institute measures to prevent aspiration. Remember, pneumonia is really what kills them, unless they don't want to be on the ventilator. Okay, so a nurse is caring for a patient with amyotrophic lateral sclerosis who is having difficulty eating and drinking. Which intervention is the priority? It is going to be B, initiate enteral feedings via PEG tube because they have dysphagia and they're high risk for aspiration. Which statement by the nursing student indicates correct understanding of ALS? And your answer is C. ALS is a progressive disease with intact sensory function. Remember, ALS, they have the senses, but it is asymmetrical loss of movement. Which nursing intervention is most important for the course of ALS? So it's going to be B, prevent immobility complications. So remember, we have to get them into rehabilitation programs to prevent contractures, skin breakdown, and other like wounds. And that is it for your other neuro PowerPoint.